Welcome to the Community Collaborative webinar for primary care practitioners. This webinar will be delivered in two parts. I will provide a presentation on the Wellbeing Collaborative. Following my presentation, Dr. Margaret Bryce will provide her perspective on the potential for the impact of the collaborative. 12 years, that's the average Australians live with one or more chronic disease. That's the second highest across the world. The US tops the league. I would like to acknowledge the Aboriginal lands and its traditional custodians, the Cammeraygal people of the North Sydney region. I'd like to pay my respects to past, present and emerging elders. As we work to serve the community's health needs, we recognise the importance of the land and waterways as an essential component of people's health and well-being. I recognise that Aboriginal and Torres Strait Islander knowledge and learning are integral to the cultural fabric of all Australians. My name is Eugene McGarrell, and I am the General Manager for Commissioning at Sydney North Health Network. First Nations people in Australia are expected to die 9 years earlier than the average population. People with mental health disorders are 2 to 3 times higher risk of premature death than the general population. And although suicide is an important cause of premature mortality in people with mental disorders, excess deaths are mainly attributed to physical disease. Health inequalities in people with mental disorders constitute a serious public health concern, and reducing the mortality gap is a health priority. We know that First Nations people experience higher rates of mental health issues, have a shorter life expectancy, and live more years with disability and disease than the average population. We believe that we can improve health longevity and health span for all. But to achieve this, we need to come together and refresh the primary healthcare system in North Sydney. The good news is that we are living longer. But the bad news is that we're living on average 12 years with chronic disease. The average number of years we live with chronic disease is 12 years, but for people experiencing health inequity, that number far exceeds 12 years. This graph shows the proportion of people with one or more chronic disease from 2007 to 2022. And as we can see, the trend is going in the wrong direction. In 2023, we engaged in a community and stakeholder consultation process to inform the new strategic plan for the primary health network. The new plan was established and published in November 2024. A key element of that strategic plan was to commission local integrated services to target health inequity across the region. We heard that there is a clear case for change. Underserved communities are experiencing poorer health outcomes. A fragmented service system leads to poor health outcomes, particularly those at risk of chronic health issues. This includes mental illness, diabetes, chronic health disease, and mobility issues. Service providers across the private, secondary, primary, and not-for-profit sectors are complex, which makes building robust partnerships complicated. The cost of service delivery is rising as demand for care rises. And poor investment in prevention and primary care is leading to increases in chronic health issues, which in turn is costing the health and community sector across all levels of government and is adversely impacting the economy. There is significant evidence that social issues have a direct impact on health. If we were to handle social issues, we will significantly contribute to better health outcomes. We know the benefits of local quality early education and care services have positive impacts on children's lifelong health and on parents' economic mobility. We understand that the economy contributes to the prevalence of psychological distress and suicidality. Life in a safe neighbourhood, living in a safe neighbourhood, I should say, with strong social connections is a protective health factor. Access to green and blue spaces promotes healthy lifestyles and social interactions. And of course, access to local quality primary care that is affordable, safe, and culturally sensitive has a positive impact on outcomes. So how do we activate underserved communities? We come together to develop local services through an evidence-based implementation process. We will start by investing time to understand local neighbourhoods, understand what matters to community, and adopt evidence-based practice. Adapting to the local service system and building local partnerships, working together to determine priorities, building capacity, and formalising plans to implement, test, and learn. We must listen to GPs, allied health staff, and others working in the primary care to really understand how best to support the primary care system. We will target neighbourhoods that are experiencing health inequity. These communities have higher prevalence of chronic disease and find service access challenging. From our consultation, we heard how low-income families find it difficult to pay for healthcare and how hard it is for them to find care that is safe, sensitive, and trauma-informed. We can deliver change by targeting underserved neighbourhoods with strong coalitions of the willing. There are examples of great work in this space that we can leverage, but we can't just pull service models from other jurisdictions and bed them down in our communities. Services need to be designed locally, prototypes tested, and we need to adapt to learning. And we should collate and share our results that are success and failures. The recent documentary on Blue Zones, which followed the publication of the Blue Zone book by Dan Butner, has attracted interest and some criticism. Despite this, the principles for a long and healthy life are well understood. We know that nutrition, exercise, social connection, and a sense of purpose play a significant role in promoting health and well-being. So we've looked at the map of North Sydney and we pulled together 26 data points of health and social care demographics across the region. This data includes information from the Australian Early Development Census and other socioeconomic data, including frail and elderly and other data points. The darker areas represent the most vulnerable neighbourhoods. The most vulnerable is Ryde North, followed by Narrabeen, then Macquarie Park, Beacon Hill, Dural, Normanhurst, and Warriewood. I won't go through all the list, but they're the top areas, neighbourhoods that we want to focus our attention on. As a primary health network, we need to work with the system. We can't and we shouldn't work alone. By bringing GPs, primary care practitioners, community, and stakeholders together, we can gain a better insight into the needs of each neighbourhood. By facilitating co-design, we can create better service models to deliver better outcomes. Creating seamless pathways of care to ensure complex care plans are coordinated and delivered. By working to a joint discipline of collaboration, we can achieve better outcomes. We know the system is complex, so we need to come together to make sure our patients can navigate their way through the disparate sectors. Connecting these sectors into a seamless system will improve experience of services and will reduce the clinical risk associated with poor continuity of care arrangements. There are examples of integrated primary health and social care models across many jurisdictions. The Froome model of enhanced primary care is a UK example. This model was launched back in 2013 as a collaboration between GP practice and the not-for-profit sector. This partnership focused on reducing alcohol consumption and reducing obesity. The results from the free model have attracted attention from policymakers across many jurisdictions. A 14% reduction in hospital admissions is compared with a 26% increase across the rest of the county of Somerset. The social benefits from this collaboration also led to a 21% reduction in healthcare costs. This compares with an increase of 21% across the rest of their county. This is a really good example of social prescribing, and people may have heard of social prescribing around the traps. This is one of the original local social prescribing models that was developed between GP practice and the not-for-profit sector. A program in Washington State focused on the evidence surrounding adverse childhood experiences, also known as ACEs. The research in ACEs the research in ACEs at the Centers for Disease Control and Prevention showed that about 64% of adults had experienced at least one type of ACE before the age of 18. Nearly 1 in 6 adults reported that they had 4 or more types of ACEs. Preventing adverse childhood experiences could potentially reduce many health conditions. Now, this data is from the US, so forgive me for that, but estimates in the US show up to 1.9 million heart disease cases and 21 million depression cases potentially could have been avoided by preventing ACEs. Preventing ACEs could reduce suicide attempts among high school students by as much as 89%, prescription pain medication misuse by as much as 84%, and persistent feelings of sadness or hopelessness by as much as 66%. Some people are at greater risk of experiencing one or more ACEs than others. While all children are at risk of ACEs, numerous studies show inequities in such experiences. These inequalities are linked to historical, social, and economic environments in which some families live. ACEs are the highest among females and culturally and linguistically diverse people. ACEs have been characterized in 2 main ways. One is in abuse or neglect, and household dysfunction of where the child grew up. Now, we know from those ACEs that there is a link between those 10 ACEs and the impact and the outcomes of those ACEs. So research shows that ACEs lead to an increased risk of health outcomes and comorbid disorders. This naturally leads to health costs and adverse impact on the economy. And this ranges from alcohol, tobacco dependence, homelessness, divorce, unemployment, on-the-job or injury, dissatisfaction with life. I mean, there's a long list of impacts around ACEs according to the research. If the cycle is not broken, ACEs will impact the next generation. And ACEs will lead to poor social outcomes and creating a cycle of disadvantage, which then in itself creates the environment to cause more ACEs. So another model that worked this time in the US in Washington State is called the Self-Healing Communities Model. And this was developed through a process of adaptation to meet the unique needs of those communities, working alongside the community to understand what matters to them was the first part of that process. The idea of distributed leadership was executed across the program. They understood that to achieve community and support collaboration across sectors, they needed to allow and facilitate leadership to flourish. Clinical leaders, community leaders, agency leaders, all working together with mutual respect for each other's roles. Creating a focus on a shared agenda is imperative, clarifying the problem that needs to be solved from the community's perspective. This focus allows the opportunity to design a theory of change that partners can all support. They took an adaptive learning approach to service design. Not setting and forgetting, but setting up prototypes, testing them in the real world, failing fast, scaling what works, and sharing the learning, success, and the failures. An agreed theory of change led to an agreed outcome and set of results, measuring the inputs, outputs, outcomes, and results to understand the impact of the model and creating opportunities to pivot as required. The results will emerge over time, but discipline focused on the logic model measures and guides the stakeholders. The iterative cycle of development creates an emergence of culture of promoting health. Prevention becomes a key principle for stakeholders. And adopting the cycle of disadvantage is supported by strengths-based philosophy for change. In turn, this builds resilience across stakeholders and communities. And some of the results that they achieved, and there's a long list of results, so I've just really pulled together one set of results for today. But if you're really interested, you can Google self-healing communities models to find a whole array of impact that they had. But, it was impressive looking at childhood hospitalization dropped according to the county that was involved in this work. And the rest of the state, it was very much straight. Looking at hospitalizations, that also went down, alcohol arrest, infant mortality, and filings for juvenile offences. But again, there's a whole array of results: health results, social results, criminal justice results that was impacted by this work. As a primary health network, and the health system generally is really focused on a whole range of results, but for us as commissioners, we're looking at the quintuple aim. So we're required to focus on delivering against those aims. Success for us would mean closing the gap in health outcomes across the underserved community groups, and that means we do that by closing the health equity gap. It would mean reducing the years we experience disease while also increasing the number of years we live. It would mean reducing the demand on the secondary health and social care system. In doing so, we are required to improve the experience of care for patients and ensure the well-being of the clinical workforce. That's a challenge, but we won't deliver that challenge by maintaining the status quo. So last month, we hosted the North Sydney Wellbeing Collaborative soft launch. We heard from people with lived experience, longevity professionals, clinicians, and demographers. What we know is the demand for the health system is going to continue to grow. The health budget will not keep up with the demand. We need to find a new way of working. Prevention needs to be a priority. We know the science that supports longevity. To achieve results, we must come together to design and deliver a new primary care system. The event was recorded and is now available on YouTube. So I've shared that YouTube channel with you guys. So I'll share that again with you at the end of this webinar. Sydney North Health Network is hosting an event for partners signed up to the collaborative on the 19th of June. And we would love as many of you to sign up as possible, because we really want to engage as many stakeholders as possible in this approach. This will be the launch of the collaborative, and the aim will be to formalise our shared agenda through a signed statement of intent or health covenant. We will then host a series of co-design workshops to support the co-design of the new primary care service model. This model will focus on mental health, addiction, and suicide prevention initially. We will then be expanding the scope of that model to include aging, prevention, and physical health. Once the service model is designed, we will go to market to attract a syndicate of not-for-profit agencies to come together and deliver this new primary care service model, which is targeted to place, which is local and focused on health inequity. The new service model will be commissioned and will be ready to go on the 1st of July 2026. The expanded service model will go live on the 1st of July 2027. The North Sydney Collaborative will be an ongoing role to support the implementation of the model, monitor the outcomes and results, recommend when and if to pivot and the service model, and ensure the needs of the community are heard, and that we listen to practitioners and clinicians in the primary care sector, as well as those that are working in the local health district and Department of Communities Justice, as well as other community agencies. We can't do this on our own. Today, we've got 81 members signed up to the collaborative. We would love you to sign up and to join this movement. The email is there for you to see if you want to join up. So thank you all for joining the webinar. Thank you. I'm hoping that wasn't. Hope that was okay. So the North Sydney Wellbeing Collaborative event was held last month, and look, each speaker provided some great insights. And what we've done is we've allocated the videos. We've created the videos on the Wellbeing Collaborative, and that each speaker has its own video. And we've also got a 7-minute short version that you can look at. If you decide to join, please email wellbeingcollaborative@snhn.org.au. Please scan the code and provide the evaluation to this webinar. That would be awesome. So now I'd like to introduce you to Dr. Margaret Bryce. Margaret is a GP owner of Bennelong Medical Centre, and a general practice in Gladesville, and her health and multidisciplinary women's health clinic in Gladesville. She's a member of the RIGCP, the chair of the RICGP Special Interest Group Business of General Practice. Margaret has been a GP in Inner West and Lower North Shore for over 35 years and is committed to the survival of general practice and the importance of trusting relationships between patients and their healthcare team. Margaret is an elected member of the SNHN Board of Directors. I hand you over now to Margaret.
Good evening, everyone. Thank you very much, Eugene, for that presentation. I suppose my role is to really try and explain the role of the GP in the collaborative framework. It was interesting for me to, as a new member of the board, I wasn't aware of the work of the collaborative very much until I went to the launch. And it was a very interesting bringing together of people and ideas who were really looking to do something a little bit different in the healthcare system. And I suppose for many of us were frustrated with where the healthcare system is at the moment, sometimes very frustrated with the direction the government takes with it. So it was great to see academics, people with lived experience, people who are working in the community services, to show what really could be possible if people work together and when people have great intent to create change. So I felt quite inspired after the launch. The criticism I would have of it, though, and I think I got feedback from fellow GPs, was the lack of GPs at that collaborative launch. And I don't think in any way that was intentional. I think it was a little bit to do with the timing of it. It was in the middle of the day and where it was located, that it wouldn't really have encouraged GPs to attend. But I think it's really important what Eugene has said, that GPs need to be involved in this. Because really, when we look back on it, general practice has been doing collaborative work for a very long time. And when I first started in general practice 30 odd years ago, chronic disease care wasn't a big part of my work. I probably had a handful of diabetics in my practice. People were dying in those days of HIV. Men dropped dead with heart attacks. We didn't have statins. And general practice was always caring for families, but there wasn't this huge community service and need within our practices. And that's so changed. The health landscape's changed. Patients have got a lot older. They're living longer, but with much more complex disease processes. There's a lot more childhood developmental changes, things that we can now see and diagnose, and where we want to intervene at an early age. And patients have a ferocious appetite for healthcare, led by social media. And their expectations of healthcare are really high. 30, 35 years ago, patients were just grateful to see their GP. But now their expectations of what they should get from healthcare providers and how good their health should be have really significantly changed. And with that, the patients also want faster, more accessible healthcare, and they also want equity. And I think that's become a very difficult space for general practice to work in. particularly because in the last 30 years, the government has moved us into a fee-for-service model, which is very time-based. And I think patients often forget that GPs are only paid for the time that patients are in front of them, and that if you spend hours a day on the phone to social services or allied health or community services, that's actually unpaid work. And with a stretched workforce and a lot of GP burnout, that extra burden is making GPs either not join general practice, new graduates don't join general practice, and GPs leave because they feel overwhelmed. So this whole idea of having collaborative care for patients fits so beautifully in with the whole idea that we've been trained with the College of General Practice, focusing on preventative care and the whole patient care, with very patient-centered, but we really need teams of people helping us to do that. What I find in general practice is the referral process for services is monstrous. So if you have a particular patient, so say I have a patient, 79-year-old woman who lives on her own, is living in rental accommodation, has no family support, has $80 in the bank, and basically lives on a pension with a leftover of about $50 each week, and suddenly can no longer afford her rent and is essentially going to become homeless. Suddenly the need for us to get services to her is quite urgent and also quite vast. Not only do we have to worry about accommodation, we have to worry about transport, we also have to worry about her mental health, we have to worry about her community engagement, reducing her social isolation, and that takes lots of phone calls. So general practitioners have become very much glorified social workers, because to get a social worker in the community is incredibly difficult. If this woman falls at home and ends up in hospital, often her stay in hospital is really prolonged. And that is because it's difficult. She has comorbidities. So one fall triggers kidney failure. It worsens her diabetes, and her fracture doesn't heal very well. So suddenly she's in hospital for 2 to 3 months, very deconditioned when she comes out. And again, there's an increased need for more and more services without any family support. So for us as GPs, we see the whole patient, we want to help the whole patient, but to access those services is really difficult for us. It's not that there's a lack of services out there. I mean, you go to lots of meetings and you see all these tables with people promoting things. But as a GP, that can be often very overwhelming. You might use 1 or 2 of those services, but often you forget who they are until you really need them. You get lots of brochures, you get lots of emails, but it is overwhelming. It's overwhelming because you're trying to tailor those to each individual patient. We really need some help in this space. But I think the main thing with the collaborative is that the GP needs to stay at the center of it. There is always the risk that when you're sending patients off to specialists, to allied health, and also to other services, that nothing ever comes back to the GP. So we have a difficulty with the referral process because it's too complex. And then we need the feedback, because otherwise the patient loop is broken. And GPs are really good at pulling stuff together if we stay connected in that loop. And so what I would want out of a collaborative approach is a streamlined referral service, but also, importantly, feedback to the GP. Because GPs are people that patients trust. It has been a long thing that we've built up over a long period of time. We often know the whole family. That's why with all of intergenerational trauma, we know every generation often in that family. We can see where the trauma has happened. We can see how one generational abuse goes down the generations, and we're treating the children of that. So I think every section of that family would be engaged in services, but someone needs to pull it together and have the whole picture. And the longer that we know patients, the better that picture becomes. So we become a wealth of trust and a wealth of information and knowledge about a family, and they trust that we will do the right thing for them. So I think that's a very important for general practice in a collaborative approach. I'd really encourage GPs to get on board with this. I know it's different. I know we're really busy people and it's hard to instigate change. But I think COVID taught us that we can pivot amazingly, given the right facilities to do that, good support, and that we will work in teams of people. And I think that we should trust ourselves that we can do this if we reach out and engage with it. The challenges, I think, coming up to us are time. GPs are so time poor. The GP workforce is stretched, and we're constantly trying to make general practice an attractive model for new medical graduates to join. So we need to make this exciting. We need to make it that's something that young graduates come out and think is a wonderful thing to do. And that general practice isn't just you working alone in a silo treating patients. It costs money, and it costs money just for the GP time, but with the services. And we're always at the mercy of government funding, which can be endlessly exhausting. But I think sometimes we have to accept small wins and also not be afraid that even if we don't succeed, that we can still keep moving forward. And not be put off, and resort back to old habits. I think it's time for change. I think patients want to change. I think there's a willingness in the allied health and not-for-profit sector to really engage with us. They're not really sure how to get in there with GPs, where they know we're so busy and often a little afraid to connect with us. But I think we have to open ourselves up to that a lot more. Patients will Google stuff. Patients will look for services, but they often come back to us and ask our advice. So it's really important that we know what's going on, so patients aren't going off fragmenting their care. Telehealth has been a great asset. I think it's been a great asset in general practice, in healthcare overall, but it also depersonalizes things. And I think patients really can do a lot of telehealth with lots of other services, but they really want to still come in and be face-to-face with their GP. They want to build that relationship. And I think that's part of the reason any of us became GPs, was to build those relationships with people. But we need feedback. We need people to tell us what's going on and not to see us as being disruptors or a difficult cog in the works. We need to accept that lots of the stuff that goes on is what we call wicked problems. They're complex. There's lots of things that impact in it. But it doesn't mean that they're not problems that can be resolved over time. And as time moves on, we may keep changing our mind. As Eugene sort of said, this model is evolving over 2 to 3 years. What we might have expected to have as an outcome in 2 years' time, it may be completely different to what we imagined when we started. But that's the exciting thing about it. And that's where collaboration is so important. So I think general practice, this is what we do. We do this whole patient-centered care. We do teamwork. We do collaboration. So I think it's really important that patients and healthcare workers see general practitioners as being a really important part of this process. So I would encourage all my fellow GPs to get involved with this. Take small steps if you can initially, but I think once we get the ball rolling, it will be a very positive outcome for us and for our patients and our communities overall. Thank you.
It's the opportunity to ask any questions that you might have. There were a couple of questions that I answered online, but are there any questions that you have?
Thanks, everyone. My name is Shamila. I'm a GP in Waitara. Thanks, Eugene and Margaret, for those great presentations. Just a question to Eugene. You mentioned that it's actually going to be rolled out initially in terms of mental health, to do with mental health first, followed then by aging, healthy aging, I guess. So when do you exactly anticipate that happening? So actually being executed?
Yeah. Well, we expect that the whole service model will be in place by the 1st of July 2027.
Okay.
So mental health, drug and alcohol, and suicide prevention by 1st July 2026. But of course, those people will also want access to primary care, physical health care, etc. And then we're looking at the funding that's used for aged care, prevention, etc., to come online to join the service model in 2027. It sounds like a long way away, but there's a lot of transition that we need to support with our current providers. And we also need to bring their workforce along with this change. And we need to make sure that we have time to really manage that transition in a way that doesn't compromise patient care, continuity of care, the workforce, etc. So we want to really do this well, yeah, over that time. Yeah, hopefully that answers your question.
Yeah, thank you.
Eugene, there's a comment in the Q&A box from Barbara around there is a new assessment tool being used in aged care single assessor IAT. I can see some information in this tool that can be used for the Wellness Collaborative.
Awesome. Great. Thank you, Barbara. Hopefully you can share that. I haven't seen that.
I was just looking at the assessment tool today. It's an integrated assessment tool. I think the aim initially may end up being replacing maybe ACAT and the ANAC that's used in aged care. But there was just things about looking at medical history, finances, social support groups, behaviour, psychology, and sort of other aspects, cognition, those kind of things. And I just thought some of that information would be quite useful, just as something to have in the background that might help with this whole initiative.
So it takes a health and social care context in that assessment.
Yeah. It looks, at the profile of the person, their functional abilities, the mobility, looking at the mental health frailty, social aspects, cognition, behaviour, psychology. I'm just rattling through the topics, their finances and support. So it starts off with a triage if people are appropriate for this. The assessment then looks at, what support services are in place that can cover this for people, or do they need to go into residential care? And if they're already in residential care and they've had this assessment, you don't have to have a whole new provider to come in for the assessment. So it's just some topics in this that are interesting. And I think it's on the My Aged Care. You can find it in the single assessment.
Okay.
Yeah,
Thank you, Barbara. Thank you, Barbara.
Kind of brought that to me, and I thought maybe there'll be something that can give some just background information. You don't have to copy anything. It's just
Yeah. Thank you, Barbara. Emily, you're on.
Hi, everyone. Thank you. That was very interesting. This is my first foray into what's happening here, so apologies if I'm missing some key information. When Margaret was speaking, I really understood the need to have GPs at the centre, and I understand the need for flow of information. When you, it sounds like you're chunking the focus groups or the steps into mental health and then aged, older people, older adults, and other chunks, which makes sense. But allied health, so people feeding into GPs, allied health professionals, and even pharmacy consultants, and everybody. We have our specialties, but we're also, some of us are specializing in some of those groups. So, for example, I run a psychology practice that specializes in older adults, and work very closely with other allied health professionals and have exactly the same problem that Margaret was describing about needing a full-time social worker to coordinate everything that's not within, sometimes it's coordinating, to hospitals, to all sorts of things. So I'm wondering if there would be an opportunity as part of this journey to get into groups with people that specialize in those vulnerable groups. So in my case, it's older adults, but there are other vulnerable groups that you mentioned. So as opposed to specializing in our allied health areas, I'm talking about like if we could come together as people who specialize in a vulnerable group. Does that make sense?
It does make absolute sense. And the short answer is yes.
Oh, great.
This is exactly what we're talking about. and it's like a real issue. This is what you're dealing with right now.
Yeah.
And this is exactly what we want to do. We want to come in and support that work in any way that we can.
Yeah.
So the short answer is yes. Let's talk.
Great. Okay. Sign me up. I'll sign myself up. All good.
Yeah.
Thank you.
GPs are often restricted by MBS billing codes. Do you think that there could be a role for innovation group consults in GP land? Yes, I do, Jonathan. I absolutely think that there is a real opportunity there. Okay, so it looks like we're coming to the end of the webinar. So look, thank you very much for attending. Thank you to Margaret for her insights from a GP perspective, which was awesome. And thank you for everyone that's organised the day today. We are recording this, and so hopefully those that registered and weren't able to be there today will be able to see the webinar also. But please, please, please sign up for the collaborative. It's really just committing to share your voice. You know, we're not looking to do. We don't want to impose any more on you, except to say we want to hear your voice, and we want your voice to really be part of the new design of services. So please sign up.